Hi students, this is the second lecture on our lectures on using quasi-experimental methods using panel data. We'll be discussing some advanced topics in different methodology. And so the two that I will be discussing, one is the use of event studies when estimating difference in difference using a two-way fixed effects model when there's staggered rollout of treatment. It doesn't all happen at the same time. And then I'll also discuss a little bit more the idea of performing placebo tests to strengthen the internal validity of your results and go through the examples of the signed reading a bit more in detail. But first, I want to start with another example. And this is one of police reform in Chicago. And in particular, this was police reform that tried to stop the stop and frisk policy. And as I'm sure many of you know, there is a big problem of racialized policing in the United States of America. And one way of many ways in which it manifests itself is a stop and frisk policy when people are quote unquote, randomly stopped on the street and checked for drugs. Mostly it's African Americans who are being targeted as a result of that. And so they're more likely to be thrown into prison with long lasting negative effects. And so, but there was this change is pushed by the ACLU, and this new change, which required in Chicago for the policemen to do way more paperwork every time they do a stop and frisk, and it might be scrutinized by the ACLU, which is an NGO focusing on civil liberties. And so, what happened, perhaps unsurprisingly, is that there was a substantial drop in the total number of pedestrian stops by the police. And this thin line indicates when this new policy was announced, and red line indicates when it actually started. And you can see there was immediately a reduction. And now the question that's asked by this paper is based on kind of anecdotal evidence that came out. Was there reallocation of police resources towards another activity, not stopping and frisking? And did that have negative consequences, especially for African Americans? And so what the study has, it has data not only on all the stops on the street, but also all the traffic stops, expanding a long period both before and after this new program was implemented, which was in 2015. It also has the types of stops and also whether it actually resulted in a citation. An actual legal infringement was documented. And so we have many periods here, not just two periods, but we only have two groups. We have the treatment group, which is Chicago, the police department of Chicago, and the control group is all the other police departments in Illinois. And so what is so beautiful about these difference in difference papers is that you can tell an incredibly convincing story just with a bunch of figures. And in many ways, the credibility of these approaches really protected by just showing visually the results in a way that's so intuitive, you don't really need a lot of knowledge of statistics to get it. And this is one of those examples where you have clearly what's going on, say, for a traffic incidents, traffic stops. And the comparison group, the rest of Illinois, was more or less flat, no change over time. But for Chicago, it was more or less flat, maybe decreasing over time. But then there was a substantial jump just as the policy was implemented and was actually increased over time after that. And so our difference in difference estimate would just look at the average in the post period subtracted by the average in the pre-period in Chicago, and do the same in Illinois, the post period subtracted by the pre-period, which would basically be zero, to calculate the diff estimate of the treatment effect on traffic incidents. But you almost don't even need that coefficient estimate because it's so very clear what's going on here. And also this assumption of parallel trends, although I made it very clear we can never really prove that, because the counterfactual is what would have happened if what would have been the trend in Chicago if this treatment did not take place. We don't know what that trend would have been. we just assume it would have been the same as the trend in the rest of Illinois. But we can show parallel trends pre-treatment. And here, like it definitely does seem that there's more or less two straight lines. If anything, there might be a downward sloping line, which would lead to an even larger treatment effect, because it's a jump right after that. So you can even visually just see that this parallel treatment seems to hold. So we have increase in traffic stops. We have increase also in the probability that Black drivers are being stopped. And we have also a reduction in citations, conditional on there being a stop, was there actually a citation? And so the story here, of course, is that whatever these activities that were targeted at stopping people on the street were redirected to just stopping people in their cars. And the motivation for the stop was that paperwork was far less in doing this traffic stops. But the same biases that were inherent in the stopping and frisk are also now at play, these biases, because there's this additional incentive unrelated to the actual traffic infringement to stop drivers, and it's mostly Black drivers who are being stopped. And additional evidence that this is not actually being very productive use of time is that all the stops don't even lead to any actual, it wasn't due to legal infringements. Otherwise, there would have been citations given. And there was a substantial reduction in them. And anecdotally, the paper also shows that there's evidence that there was just this new performance metric that all the bosses were pushing was more traffic stops, because the stop and frisk was no longer possible. Right, and so how do they estimate this in the model? They use this beautiful, very simple difference in difference estimate that you are now aware of, where Chicago refers to whether it's Chicago or another police department, and post refers to whether it's after the reform was implemented or before. And then you can have now, again, we only have, even though we have multiple time periods, we only have two dummy variables here, and then the interaction between those two, whether it was Chicago or not, and post reform or not. But now you all know what the interpretation of these different coefficients are, but let's go through it. Repetition is the best way to learn. Alpha 0, of course, now is the mean outcome when all of these other terms are equal to 0. So that is the mean outcome in the rest of Illinois, not including Chicago, in the pre-period. So just averaging out, that would be, for example, the mean in this period there. The outcome is traffic stops. And so alpha 1 here is the difference between Chicago and the rest of Illinois in the pre-period. So this would be subtracting this value from, well, subtracting this value from this value. There's a big negative number for traffic stops because there were way fewer traffic stops in Chicago relative to the rest of Illinois. And this beta 1 coefficient is the change over time, but this is just the difference in the average in the post period compared to the average in the pre-period for the rest of Illinois, excluding Chicago, when Chicago is equal to 0. And then this beta 2 is the one we really care about. This is the difference in difference estimate of the true treatment effect, which can be interpreted as the change in outcomes in the treatment group subtracted by the change in outcomes in the control group. Right, and they find incredibly large results here. And so if you have a log on the left-hand side, you probably know that you can interpret this as percentage change, and there seems to be a traffic doubling of traffic stops. The probability that somebody is Black additional being stopped is increased by 12.8 percentage points, and incredibly large reduction in the probability that there was actually a citation conditional on being stopped. So these are very large results. Very just quickly, a side point, you don't see any stars here. There is a convention in many studies these days, which is good, is to not actually show the stars indicating statistical significance, because we should really care about the coefficient estimates. In this case, all of these would just have 3 stars because of the way their sample size. But a rule of thumb is you've got to take the coefficient and divide it by the standard error to get the t-value. And then if it's 2, then it's it's a significant under 1% level. So you can always eyeball a little bit. And like here, the value is 7.014 divided by 0.02. So like these are all massive numbers. So like significance is not an issue that you should concern yourself here. Right. So just an example of a very compelling story that can be told, and very nice to just use a simple 2x2 framework to estimate the results. But this is just in one city, right? And we have thousands of cities in the country, and 50 states in the country. And this is why I want to transition now to talking about event studies, which are really the methods that are used to investigate or examine the impact of all of this experimentation that is taking place in the United States because of its federal nature. And this is why the textbook reading, which is assigned reading, is from Scott Cunningham, a very irreverent and very entertaining read. And so he has a bumper sticker which says, "I love federalism for the national experiments," because you have all these different states trying different things at different periods in time, and you can often estimate that the impact of these policy changes doing this difference in difference, especially using this event study design. Of course, it's not only in the United States you can do this, but it's most commonly applied in this setting. Right, so what are event studies? It moves on beyond our classic difference in difference, which just had 2 periods and 2 states, treated versus non-treated, pre versus post. Sometimes we have multiple time periods, and we have multiple units that receive treatment, but they get treated at different periods in time. They don't all get treated exactly the same time period. So we can't draw that really nice, very easy figure of just showing over time treatment versus control, because each treatment group might have a different point in time when that transition happens to treatment happens. And so there are numerous examples, but just a couple of examples of studies that are referred to in the textbook chapter is one is we'll be talking about directly is expansion of Medicaid that happened in different years for different states. The repeal of abortion laws. There are some fascinating studies I'm sure many of you are aware of, just looking at the impact on demographics 15 years later or 20 years later, based on the hypothesis that there are some people who are not wanted, people who would have been aborted are those who are more likely to suffer from social ills because they're just not given the same kind of care and attention. And so, you would expect high crime rates or like lower crime rates if abortion is legalized a decade or 2 down the line. And there was a variation in when abortion was deemed legal. 5 states repealed it in 1970 before all the other ones followed suit in 1973. Now we're going to have a bunch of other studies come out, unfortunately, in a couple of years' time, because we're going to do full cycle, and now states are going back into implementing abortion again, or like making it illegal again. Sidetracked, and so minimum wage as well as an example, where different states all across the country have their own different minimum wage laws, and they're changing in different periods in time. Another example from the textbook is the stand your ground law, where its definition got extended to outside your home, which basically means it makes it much easier, or there's more legal impunity to commit violence against other people and to claim this ridiculous law that I was just standing my ground. And this was kind of this interpretation of the law was extended towards 21 states, but over a period of a decade. So all of these are examples of like different states receiving the treatment at different periods in time. And so the way that this is often then estimated You can still estimate a difference model, but using a two-way fixed-to-fix model. And so what do we have here is, once again, we have the outcome by subscript Y, S, and T. I, S, and T. I is for individual I, who is in state S. This could be any kind of group, but if this is variation at a state level, it could be state S, whatever level the variation of treatment is, and period T. So this is panel data and multiple observations over time for each individual. And then we throw in these state fixed effects, different dummy variable for every single state, and time fixed effects, a different dummy variable for every single time. In this specification here, I'm not actually showing you the beta 0 you always see as a constant term. It can just be subsumed in the state fixed effects. As you guys recall, you can just have either one state the fixed effects gets dropped out, or you just don't have a constant term. Just for simplicity, often it's written without including that, because then you just focus on the parameters that really matter. X just refers to a vector, which is just a bunch of different controls that could be included, but they need to be time varying. We're not even showing the coefficient there because that's not relevant. What's really relevant only is this delta coefficient on DST. And so what's very important now to understand that this treatment variable is equal to 1 in the periods that the state is treated, right? So maybe treatment only occurs in periods 5, 6, and 7, and periods 1, 2, 4, this variable will equal to 0, but in this state, it'll switch to be equal to 1 in periods 5, 6, and 7. This is analogous to the treat times post variable we were using in the diff and diff framework, because that was equal to 1 in the periods that the treatment was actually taking place, right? Where treat was actually equal to 1 irrespective of what time, it's just if that state at any time received the treatment, treat is equal to 1. This variable DST is equal to 1 only in the periods when the treatment is actually taking place. And so this is incredibly appealing framework because it sort of seems as a kind of logical, kind of more flexible way of doing difference in difference, where instead of having just a post variable, we have this control way more flexibly for different time trends and different control for every single time period. And instead of a state, the treat variable, we have the state fixed effects. So it's far more flexible way of doing it. Alas, turns out only recently have we being the academic community discovered that there's actually a lot going on behind this estimation when you have the staggered treatment. And you run into trouble when the staggered treatment either has heterogeneous treatment effects or it's time varying treatments. And there's a bunch of papers that have really befuddled all applied researchers looking at this, and memes have flown trying to just make sense of this new literature. But all of it has sort of come through to show that this approach, we can still estimate kind of meaningful parameters. We might have to make some very small tweaks to this canonical model, but the difference has survived this new literature. And I just want to quickly show you through one example of a recent paper by Goodman-Bacon that sort of tries to unpack and understand what exactly are we estimating when we do this two-way fixed effects model. And this is just good for you to understand the intuition. This won't be examined, but the intuition of what this is actually doing, this model. And so when we have staggered treatment, there's a stylized example you can see here. We have a kind of trends over time for 3 different groups. So this group K, this first group, received treatment first. This red line is when it receives treatment. You can see all of them had the same ongoing like counterfactual trend, but there's this one big jump when treatment takes place. I don't know, maybe health outcomes improve substantially because of expansion of Medicaid. And then after that, things just go on, this time trend is the same as before. There's this other group, maybe it's another state that expanded Medicaid a bit later. at a much later point is there this jump in its outcomes and improvement in outcomes because of the treatment. It's a later treated group, and then there's this untreated group. Of course, you could have multiple different, you can have not just the early and late, you can have all a different year, a different group gets treated, but you just need this to understand the distinction between early and late treated groups. And so this delta that we're estimating, this kind of two-way fix-effects model, is actually capturing a bunch of different comparisons that the OLS is making at the same time. And one of them is a bit counterintuitive. And that's the one that can give us trouble sometimes, depending on the setup of the data and the specifics of the program. So first is you have this early group that's being compared to the untreated group, right? The classic difference in difference. You look at the mean post for treated, subtracted by mean pre, and subtract that with the which is the mean post subtracted by mean pre in the untreated group. You do have the same four groups, so the difference you can do here. You can do the same thing with comparing the late group with the untreated group. Again, just looking at the mean outcomes post for the late treated compared to mean outcomes pre for the late treated, and the same. Compare that with the differences in means for the untreated group. The same difference in differences we did before. And the early group can also compare its outcomes to the late group, right? Because the late group hasn't been treated yet. It can also serve as a control, as a comparison group for the early group, because this is also at an untreated period. But what it also does, this estimate, is it also uses this early treated group as a comparison group for the late treated group. And the idea here is that when you do the difference in differences, you really look at like states that have changed the treatment status and what happens to the change in outcomes. But in this late treated group, it has already received its treatment, right? It's already gotten its benefits from whatever this treatment is. And it can also now serve and it does serve in the D&D model as a comparison group, because it is not changing its treatment status at this point. And this is something that I did not understand beforehand, and many people did not, that this is also, as part of this one difference, two-way fix-effects estimate of delta, it also incorporates a part of that is also, it's a weighted function which also includes this two-way comparison, four-way comparison, difference estimate, comparing using the early treated group as a control group. And this is fine in this case, because where they just had the same trends over time, and there was just a stepwise increase in improvement in outcomes. But you might have a situation where this early treated group now with this dotted line might actually be have a whole new trend of outcomes after being exposed to treatment, which leads to a cumulative treatment effect over time. You can see here it's just increasing over time. For example, if this is an expansion of Medicaid, maybe over time, it just took time for people to enroll and sign up and to receive the benefits of Medicaid. And so this benefits and health outcomes have just been expanding over time. The problem then is if you want to use this as the comparison group, the same group, like you are actually comparing this with a group that is also benefiting from the treatment at the same time. And the implication of this is that if the treatment effect is increasing over time, you might be underestimating the true treatment effect, because your comparison group is also a rising tide of a group that is also still benefiting from the treatment. And so this is something that we are now more aware of. And it's really only an issue if you have a lot of these early treated units that receive treatment far earlier, and they end up at the end of this data set being used as a comparison group. But there are many ways to overcome this problem. One is to have a more flexible model that examines dynamic treatment effects. We'll discuss this in a moment. And there's also some robustness you can do to just kind of drop these early treated groups from the sample, or not use their observations at the end when they're used as a control group. nothing you guys will ever have to do unless you end up your thesis being using this kind of data set. Just something I think you guys would enjoy to be aware of. But now moving on from this two-way fixed effects model, we actually, if we think there might be dynamic treatment effects, we might want to have an even more kind of complicated model. And this more complicated model also helps us test for the parallel trends pre-treatment. And what we actually have here now is the same model, but we don't have just one dummy variable equal to 1 if a unit is treated at a certain period in time. We threw in a bunch of lead and lag variables. Now, if you guys remember, lagged means like, you know, if treatment happened the year before, or 2 years before, 3 years before. But on top of that, because like lag treatment, adding lag terms allows you to say, like, you know, what happens to the outcome 1 year after treatment? What happens to the outcome 2 years after treatment, 3 years after treatment? But the leading terms is estimating the treatment effect 1 year before the treatment actually took place, which is weird to think about it that way, but it's a test because you would expect these alpha k's to be 0. You would expect there to be no quote unquote treatment effect prior to the treatment actually starting. But by having this model like this, you can actually test for this directly. And I just want to show you guys in a figure, in an example, what exactly is going on when we throw in these all these lagging and leading terms of treatment assignment. Now, here is an example of exactly the same setup actually as the paper on mobile phone penetration. You have 3 different groups, 4 different time periods. At a different period in time, a different group starts receiving treatment. Group 1 receives it in the second period and then subsequently remains treated. Group 2 receives it in the third period and then remains treated, and group 4 receives it only in the fourth period. And so what we can do now is, if we want to create this lagging term, sorry, this leading term, we have this D -1 term, which is treatment the year before treatment actually took place. We just have this dummy variable equal to 1 the year before treatment started. So in group 1, treatment started in period 2. This variable is equal to 1 in group 1 in period 1, which is a year before treatment started. The same way in group 2 is equal to 1 the year before treatment started. Because treatment started in year 3 for the second group, this is now equal to 1 in year 2. And the same way, for the third group, treatment started in the fourth period. This term now is equal to 1 the year before. The contemporaneous treatment term here is just equal to 1 at the year that the treatment started. So it's equal to 1 here, equal to 1 in the second period for group 1, equal to 1 in the third period for group 2, and in the fourth period for group 3. And the same way, we can also create these lagging terms where D1 now is equal to 1 the year after treatment started. So for the first group, treatment started in period 2. So this is equal to 1 in period 3. And similarly for the second group, treatment started in period 3. This is equal to 1 in period 4. As you can see now, we have this kind of bunch of mutually exclusive, collectively exhaustive dummy variables indicating a bunch of periods before or after treatment actually started. And if you throw all of them in together, you can basically estimate the time sequence of treatment effects, both before and after the treatment actually took place. And the main reason is because we can't actually have this beautiful little figure like this showing this kind of before and after treatment, because each group started treatment at a slightly different period in time in the event study group. Right. So after I have now shown you how these variables are constructed, I just now want to show you, go through this example we have of the expansion of the Medicaid to see how throwing in all of these leading and lagging treatment terms can help you show this evolution of the magnitude of treatment effects over time. And now to clarify, I only showed this for one lagging and one leading indicator, but you should do it as far as you can, right? So you should have 2 periods after treatment, 3 periods after treatment, 4 periods after treatment was started. So let's look at this case study of the expansion of Medicaid. And so this is a fantastic study that kind of experiences variation in exposure to Medicaid because a part of the Affordable Care Act 2014, all adults and families with incomes under 138% are now also eligible to receiving Medicaid. So this whole new segment of the population of the country can receive Medicaid. However, because this is America, the states didn't always take up on this offer, and only 30 states actually expanded coverage, despite the fact that the federal government gave this to them for free. And so they, out of principled reasons, their freedoms would be taken away by giving benefits to their citizens at no cost. But this created an opportunity to estimate the impact, because there are these states now that did not receive this expanded coverage, and we can look at those individuals who would have received it in these control states and see what happens to them. There was a bit of a staggered expansion. It didn't all happen in 2014. Some of it happened in 2015 and 16, which requires using this kind of event study mechanism to visually be able to demonstrate whether there was kind of balance and parallel pre-treatment trends. And so, this paper is called Medicaid and Mortality, New Evidence from Linked Surveys and Administrative Data. And so these authors do a fantastic job. They combine a bunch of different data sets to get them data on socioeconomic data, and they need the data, socioeconomic data, because they only want to look at poor families who are now eligible to receive this Medicaid. They don't want to look at the impact on the full population of US citizens. And so they are able to find a sample of 500,000 respondents who are eligible for this new, who would be eligible for this new transfer, for this new expansion of Medicaid. And then their primary analysis focuses on elderly, because the only outcome indicator that they can have is actually mortality. And so, of course, the elderly are more likely to, or more at risk of dying, right? So they don't have detailed health data except for just whether somebody is still alive or not in a given time period. And they have also data on whether they actually ended up enrolling. And this is a case where these figures are just so incredibly powerful. You don't even need to understand the method that well to know that this is very powerful. And now there's this dot there this is point -1, and so this is the one leading term, which is where the treatment took place the year, the dummy variable equal to 1 where the treatment took place the year before, is excluded. You need to have an omitted category because you have all these different dummy variables you're throwing in. And so what the omitted category is often just the year right before treatment started, right? And so this is the omitted category everything is being compared to. And so what this coefficient -2 shows is like alpha -2. It just shows that like effectively looking at the trends between 2 years before expansion and 1 year before expansion, comparing treated and untreated states, there's no difference in these trends. It's kind of doing a difference estimate between time -2 and time -1, looking at the changes in the quote unquote the treatment group versus control group. And the fact that there's no differences here, very precisely estimated 0, just means like, okay, there's no weird stuff going on even before this treatment was implemented. but then this massive jump right after the expansion took place, which can just give one a lot of confidence that like this is really a strong mechanism here at play, which is the expansion of the eligibility of actually receiving this Medicare. And so this kind of first result is just on whether these people are not eligible to receive Medicaid. It's kind of almost mechanical, but it's what we would see in a couple of weeks. We'd often call the first stage. It's just like at the outset, we haven't looked at the outcomes yet, but at least in terms of the eligibility, their actual reception of this treatment, there is this increase. And so now we have much more faith that we're actually investigating something which is meaningful. And then coverage, we're looking at whether people are actually enrolled in Medicaid. We also see the same kind of situation. There was no differences between treatment and control over time before the expansion, and at this expansion period, a big jump, and even slightly larger jump, and then it stays pretty much constant after that. And then they have this very convincing figures on mortality as well, where it's not very precisely estimated in this case, the pre-treatment, but they're all just hovering very close to zero. The confidence intervals all fall around zero. So you can kind of reject the null that there were kind of differential trends taking place between treatment and control, future treated and control units prior to the actual treatment taking place, but a kind of very consistent reduction in mortality rates prior to the expansion of Medicaid. So this tells just an incredibly powerful story using this event study design of the fact that there's zero trends, differential trends taking place prior to the treatment makes us have more confidence that there's not something else going on. And it's really this kind of the treatment itself that happened at this point T that is really driving the results. I want to just add another warning label here, is that part of the kind of destruction of difference in difference models recently has also found that even this approach, this event study approach, can lead to some very weird estimates if treatment is staggered and the heterogeneous treatment effects. But again, it's only really concern if you don't have any never treated groups, if you have like all of your units end up eventually receiving the treatment. But in this case, the study, it's really, there isn't a lot of staggering. It's all happened more or less 2014 or 15. And there's a big group of a controlled state that never actually received the expanded Medicaid. And so they did a bunch of tests that are required to show that there's actually like these are legitimate estimates. And so once again, this new literature that has shown that developed a bunch of new ways of estimating treatment effects in event studies. And unfortunately, it is beyond the scope of you and most of us to learn all these new methods that have just recently been applied in the last couple of months. But if you are interested and you'll be doing your thesis using event studies, it's a fascinating area of research, a lot of groundbreaking stuff being done, and I definitely, there's a reference here for all the knowledge that has been acquired in the last couple of years.